Welcome to our weekly edition of What's Up Doc, our Ask a Doctor series. We're incredibly lucky to have this week's wound care specialists because when it comes to peripheral artery disease, which is that poor circulation in the legs, when it reaches advanced stages, you can get wounds on your feet that won't heal. And a lot of these patients with poor circulation in their legs, known as the peripheral artery disease, when they end up going into advanced stage critical limb ischemia, where the wound gets so bad because of poor blood flow that they end up at risk of amputation, they really need a great wound care specialist, such as Dr. Reza Rohani with Los Gatos Private Advanced Wound Care Clinic and his nurse practitioner, Lihia Abohande. I hope I said that right, Lihia. Thank you so much to you both for joining us. Also, I failed to mention that diabetes is a huge risk factor, and you don't even have to have peripheral artery disease, which is those blocked arteries. You could have some capillaries that are not getting that blood flow to the point of the wound, and that can be a diabetic wound. And all of that is just a big problem. Once you get those wounds that won't heal, that's just trouble. And that's when you need a doctor like Dr. Rohani and also his nurse practitioner. So we appreciate you guys being here. You're in Los Gatos, California, San Francisco Bay Area. So thank you so much, you both, for being here.
My pleasure. Thank you for having us.
So I'm thinking, where should we start? Should we start with you, Dr. Rohani, and talking about your journey into general surgery and then what led you to specializing in wound care? And then we'll go to Lihia a little bit on her journey into wound care as well.
Hi, this is Reza Rouhani. I'm a surgeon more than 30 years and I'm chair of the Department of Surgery at Good Samaritan Hospital. And I'm doing surgery, as you mentioned, 30 years, but recently I figured out there's a big problem in the wound care and they need more attention in this part. And then we find Leah, and she came to help us, and we create this advanced wound clinic in our area. And now we are getting more cases, and we're trying to help the patient in our area to get the wound healed and take care of that.
And Lihia, you're a nurse practitioner, correct?
Yes.
How did you decide upon wound care as a specialty for you when there are so many different practices for nurse practitioners?
So I'm a registered nurse, and I decided to go for nurse practitioner. Since I started to become a nurse, I did wound care. So I've been in the system for about 8 years, and all I did was wound care, and I really like wound care. Um, we don't just like the whole of the patient. We want to treat the patient as a whole. And I started seeing a lot of my patients having diabetes, venous ulcers, pressure injuries, any type of wounds. And I just decided to become a nurse practitioner so I can continue to help the community, but at the same time, be able to prescribe the medications that I need for the patients.
You bring up such a good point. I talked about peripheral artery disease wounds and diabetic wounds, but another really prevalent issue are venous wounds, chronic venous insufficiency that, we currently have a very high profile case, doesn't matter where you fall politically, but with President Trump being diagnosed with chronic venous insufficiency, that's something that can quickly get out of control. And advanced stage CVI, or chronic venous insufficiency, can result in wounds that aren't healing on your calf, correct?
Yes, that's correct.
And so I bet I'm wondering if, since the revelation that President Trump has it, have you seen additional cases coming your way with that, with more people saying, hey, wait a minute, I have a wound here. I now think maybe I have chronic venous insufficiency with this wound that's on my calf.
So in the hospital, because I also work in the hospital, we do see a lot of patients that come in with leg wounds, and it's so difficult that they come in when it's already like to the worst. And then we try to stabilize them, and then that's when we are here as an outpatient. When they get discharged from the hospital, they can come in and we can continue their care, because that's when you need the most care. When you get home, they don't know where to go. So yes, we have seen more cases.
So I'm curious, Dr. Rahani, how is your experience? Because you're a general surgeon. You've dealt with both internal, external wounds. How has that shaped your approach to patient care?
The point is the wound care is the very sometimes it's quite more difficult and very complicated. We need to get multidisciplinary approach to take care of the wound. It's not like the just wound. We need a vascular surgeon, sometimes podiatric surgeon, and different specialty to come and help us for the take care of the wound. But over the my experience and I think the wound healing kind of the art because everybody is different with a different problem and we need to put together to be able to help that. So, but that's we are multidisciplinary team. We have a different group to helping us. We can refer to the vascular surgeon or the other group. Sometimes we can send for the patient with hyperbaric oxygen to help for the wound care, different modality to help for the wound care.
So what types of wounds do you most commonly treat, and how does your approach actually, I know this is a loaded question, but how does your approach vary depending on the wound type?
Yeah, we have a patient with the big bed sore, and we have a patient with a surgical wound, and the open abdomen, then close and big opening in the abdominal wall, and also we have a patient with the extremity wound, and as she mentioned, we have a venous ulcer, and we have a diabetic foot, and different type of the wound we are able to take care of in our office.
The beauty of having a general surgeon is that you can take them to the OR and debrief them, get those wounds cleaned up really well in the OR, and then get them ready to discharge. There's also skin subs that can be used in the OR as specialty dressings, so we can follow as an outpatient.
Yeah, and so I want to talk about that outpatient. We'll get into some of the details of some of the advances in wound care that I'm really excited to talk about. But you guys are actually, you mentioned that there is the hospital setting. You do have access and hospital privileges as well. You have access to the OR if the wound needs debrided, cleaned up a little bit. But you're in an office-based facility, an outpatient facility. What sets your wound care clinic really apart from more traditional hospital-based settings when it comes to wound care?
Yeah, obviously, we can do the debridement in our office too. We can close some of the small wound too. Yeah, we can. The small procedure we are able to do here, but as she mentioned, if need a big, debridement and need some kind of flap, something like that, we can take the patient to the hospital OR to do that. But we have a lot of option with the skin substitute, and that's going to help a lot recently for wound healing. And we are seeing good result, honestly, with this kind of the material, and we're happy with using those.
So let's say we bring a patient from the hospital, but they still have that big open wound. Here in the office, we're able to, like when it continue to heal, he is able to do partial closure until we're able to close it all the way without having to take them again to surgery. So that's the beauty of having it as an outpatient, because we can close them without having to go again to the hospital to have that done.
Gotcha. Okay. So, do you offer any particular treatments that are less commonly available in a hospital setting?
So in the hospital, I mean, it's either, you take them for debridement, you leave the wound open, put a wound back, or you close them all the way and hope that it's going to stay closed. Inpatient and outpatient are similar. The only thing is, sometimes patients cannot have a second surgery, maybe because of their age or complications. So that's why the outpatient is so we can continue to provide that wound healing without having to have that trip to the hospital. And the skin salves, we can use them. There are skin salves that they can only be used in an outpatient setting. So then we were able to use those for the wound healing for the patients as well.
And also the wound healing need time consuming. It's not going to be happening just in 2-3 days.
Yeah.
That's going to save the patient to stay in the hospital for a long period of time for the wound healing. If they come into the office setting, they are able to go home and have a normal life and come back every week, or based on the situation we can make a decision. But they don't
Yeah.
need to be in hospital. They don't need to be admitted for just wound healing. They have opportunity to have a normal life, but they just come to office and take care of the wound.
So what advances? I know that Leia, you mentioned a couple things, but what are some of the most advanced wound care tools or techniques in your practice that you are most excited about, or that are the most transformative at this point?
So for wound healing, like he said, it takes time to heal a wound, and you're not gonna heal a wound in a week. So in order for wound healing, you have to do a little bit of debridement. You have to provide with the correct treatment plan in order to heal that wound. So what do I mean about that? If the wound is too wet, for example, if there's too much drainage, I need to make sure to put something that will absorb that drainage so the wound can continue to heal. But let's say also there's necrotic tissue that needs to be cleaned. You need to also do debridement, clean that, and the healing process will continue.
But
Are
regarding the
you?
advancement in the wound care, I
Yeah.
would say the most, in my mind, most advanced part is the wound vac. The wound vac is a machine we can put over the top of the opening area and connect to the machine. They're going to suck the wound for 24/7. And that's the significantly improve the wound healing, accelerate the wound healing, and also, collect all of the moisture and that's I would say one of the most advancement in the wound care we have right now. But also, as we mentioned, with the skin sub is other very advanced way to help for the wound healing.
Now, I'm not sure if this is new, but they're doing a study in the United Kingdom under the NHS for what the doctor describes as a toothpaste-like material for patients with osteomyelitis, and they can go in and put this toothpaste-like material into where the infection is in the bone, and they said they are seeing miraculous results with this manual placement of antibiotic versus through IV. And I heard it was actually used in more general surgery and orthopedic surgery, and is only now being applied to people who have osteomyelitis in their feet. And I don't know yet if it's being done here in the US, but they're definitely studying the application in the United Kingdom right now.
The osteomyelitis is complicated case there's not the one case. We have to do how bad is the involvement of the bone. And that in this kind of case, we usually ask the ID to be involved to help for the treatment of antibiotic. But the local treatment compared to the systemic treatment sometimes need to be together. And I don't think
Yeah.
we should say one way for the osteomyelitis, because we don't want the patient to lose the extremity or some part. We have to make sure we are able to treat the osteomyelitis in the right way. But in our case, most of the time need a systemic treatment or antibiotic. But if we can add some local treatment, but most likely need some adjuvant,
Yeah.
systemic one.
It's great that you have all of these different options available to you. And I'm curious, what is your philosophy on balancing surgical intervention and then versus non-invasive therapies when it comes to wound care? And I know it varies based on presentation of wound and disease.
Absolutely. Yeah. We are going to base on the situation, but we try to be less invasive as much as possible, as less as possible. But as we mentioned, if the patient need to go to the OR, need to go OR. You need to take the patient to the OR to do the big debridement. And or sometimes need a flap. But that's, we mentioned every case as a query, and we have to make a decision based on the reality of which patient in the ward, big treatment.
And like I mentioned, I mean, we don't just look at the hole in the patient, we look the patient as a whole. This include like nutrition wise, you know, in nutrition here in wound healing plays a good, important role in order to heal the wounds. So sometimes patients just need a little kick to get that nutrition going, so the wounds can continue to heal rather than having them, you know, to take to the OR. So we will always start with the approach that we can do outpatient before thinking about more aggressive treatment.
I love that you bring up nutrition. It plays such a really great role, especially, you know, when it comes to making sure that they're getting enough protein. There's a drink called Juven by Abbott that we end up buying for a lot of our patients that can't afford it, who have wounds that aren't healing, because the doctors say you need to have it. You need to improve your nutrition to help with wound healing. So I'm curious, from your perspective, how do you educate the patients about these types of things that they have to do outside your wound care facility, especially when it comes to treating chronic or complex wounds, and that includes eating right and drinking right?
So, you know, we do recommend our patients to take Juven. We always tend to forget that skin is the largest organ in the body. So if you don't have good nutrition, no matter what type of treatment we do, those wounds are not going to heal. So we provide them with written materials, and then we tell them to get the Juven, to take it twice a day, at least for a month, to help that wound healing. If there's other, we also have, we can do a lab to check their albumin level to see where the level is. That also can prevent wound healing if it's too low. But a lot of it is with the resources we have in the community, written materials or videos, or we can give them, we can also refer them to a person, a nutritionist, that can tell them more specific nutrients that they need for wound healing.
How do you monitor these patients? Because especially, do you have home care nurses as well that go out in between appointments, or do you have a certain schedule, especially for those patients that have the more complex wounds that may need you know, at least some monitoring or wound dressing changes a couple of times a week?
So we do put them on home health care. So they have a nurse that comes to their home twice a week, and then they come here once a week. The patients that do not qualify for home care and they might need extra care, we have them come to the office, and they might have to come once or twice a week, and then we will take care of their wound. But we always find like a resource to provide that care if it needs to.
We're monitoring the nutrition in sometimes start with checking the labs and the patients, you know, albumin, p-albumin level, and also we doing every time they come in office, we checking weight to make sure they are not losing weight, they are gaining, you know, that's the, we monitor the patient's weight to make sure they are able to, you know, get enough calorie and protein. Also, as you mentioned, is the education is part of that, you know, we have to make sure they are taking more protein to help with the wound healing. And one of the other problem we have is the obesity and the nutrition part. Some patient coming with the source of the problem is the patient's obesity. We have to do some other way when after the wound heal or during the wound heal to do some kind of the weight loss program to help to prevent the wound to be happening again. This is the other problem we have with other patients, you know, they come in with some kind of the wound related to the patient's obesity.
And that is an issue, especially when it comes to people who are diabetic and people who have chronic venous insufficiency, that weight loss is critical to making sure that those wounds not only heal, but they don't come back again. You got to make sure that there's proper circulation, and the less weight you have on those legs, the better that you're going to be. What I love in terms of what you're talking about is, usually our organization ends up having to say to these patients, hey, did you get the blood work? You know, what are your nutrient deficiencies, vitamin deficiencies? Have you gotten a vascular evaluation? Are you getting regular vascular evaluations? Do you have a home care? Like, we're having to do all of this. They're calling us and saying, hey, we don't know, should we be changing our dressings? what should be watching out for. I mean, I even had a patient that called me one day and said, "Hey, Kim, the wound care nurse was here yesterday, but suddenly, I don't know, something feels really weird." And I said, "Okay, well, I'm not a clinician. I'm going to tell you to get to the emergency room right away, but just open up that wound and just see what's going on." And there were maggots
Mm.
all in there. And the wound
Mm.
care nurse was just there the day before. I couldn't believe it. And she had maggots all crawling around. I'm like, you need 911 right now. You get to the hospital. So I don't know if you see these types of situations that they're already train wrecks by the time they come to you. And then how do you handle those types of situations where you have to kind of reverse engineer the entire everything, undo what's already been done or not done?
Absolutely. Yeah, we have a patient actually came with the wound. They take care of for months, and that under the area was the tumor invading that area with the fistulas in the bowel. That's sometimes so difficult and need to be different type of approach. And as you said, this is not the nutrition is one part, multidisciplinary approach is one part, and also be careful about what we are dealing with. That this is sometimes they need more expertise, and need sometimes wound care need to be observed and make sure they are doing it the right way. Yes, correct.
Now, for
Yeah,
those
I
patients you're talking about, the maggots and stuff, in that type of situation, like you say, you told them to go to the ER, we probably would have done the same, to go over there, get the wound clean, and then we restart over, and then we move to the outpatient again to try to heal those wounds.
yeah, because those maggots actually do a pretty good job.
Yeah.
They're not the maggots that you definitely want just for the ones where they're flying around. Don't go down the road and find an animal there and the maggots that are around there. No, these are special ones that are actually clinically raised and they're in a sterile environment that are used in still some facilities, which I've seen is pretty incredible. But in terms of patients that are looking for the right wound care, we have patients across the globe that are tuning in right now. What are the key criteria that they should be using when choosing the right wound care center for them?
Well, for example, our clinic, like he said, we work with different type of doctors. So if our patient, let's say it's a vascular patient, we work with a very close vascular doctor, and if they need vascular tests, we will send them there. But then they will continue to come to our clinic to receive the treatment plan that they deserve. If
Mhm.
it's plastic, we also work with a plastic surgeon that we can just call in and she will see the patient as well. Instead of having multiple different clinics, you can just get everything in one. And then it all depends too on if the patient, the insurance, and then the insurance is cover our practice, then they're able to come in. We also, if they don't have, let's say, like I mentioned before, home health, we
Mhm.
will make sure that they will get the care. If there's nobody that can go to the house, then we will have them come here and we'll make sure that we can provide the care they need.
Can you share a patient story that stands out to you and that, really illuminates the type of care that you provide at your facility?
Actually, I have recently one of my friend, and she had a wound, and I had to take care of the wound by myself, and all. I was a wound care nurse, and I was everything for her. And I thought this is very difficult for patient because I was seeing how much impact the wound healing has on the patient's life, and then it's really important how we are dealing with that, and this, this involvement with the patient's wound to help me to see how much we can help to make it faster is going to help patient to come back to the work faster and have a good life, and have a wound back for a long period of time. They cannot do whatever they want. They cannot go to the party. Sometimes it's getting noise. This is the situation is the help me at least recently to see It's very how much important the wound healing for the patient.
I
It's
can
a really,
tell
go ahead, Lydia.
I can tell you one patient that we had, let's say they're in a nursing home and then they come in to see us and they had a wound vac on the bottom. The bottom is really difficult area to sometimes place a wound vac dressing because it's very close to the rectum. So if you don't put extra things to keep a good seal, that dressing is not gonna work. So this patient wasn't happy with the nursing home, for example, so he decided to go home. Then we have him come in here. We will do his dressing, and every time he came here, it was the only time that his dressing will stay in place until it needed to be changed. So he wasn't having any issues. So instead of having the other place touch the dressing, then he will come here twice a week. We'll take care of the wound until we heal him. And then he was so happy that we were able to help him out and he didn't have any complications. And he healed faster because the wound vac can actually heal your wound double the amount of time, decrease the amount of time of healing rather than just doing the typical dressing changes every day.
Um, you bring up a really good point in terms of this wound healing, it's really time consuming. And we hear a lot of times from vascular specialists that, you know what, with these patients that have these wounds due to poor circulation, I mean, they're not diagnosed soon enough. So you end up with these really serious wounds, severe infections, and yes, can they save it? They can go in and open up the arteries, right? They can provide all the wound care. They can provide the hyperbaric chambers, but that becomes a full-time job for anywhere between 3 months to 6 months. For some patients, I've even had them with one wound, but they're still healing a year later. And there are a lot of doctors that have that school of thought to think that, you know what? A year of wound healing versus just chopping off that leg and getting you a prosthetic within a few months and be done with it. Well, that's the better option. I'm curious from your perspective, being on the front lines every day and doing these wounds and understanding the advances and when wound care is done right. What is your thought about that type of philosophy? Do you have that conversation with your patients?
We go the limb saving. We try to save as much as possible, and it's this very important to patient to save the part of the limb if we can. And we don't want to go to the chopper first. We try to save as much as possible and try to do all multidisciplinary approach to save the patient's limb.
We will do first everything that needs to be done before even thinking that we need to, remove a part of the body because, maybe it might take a year, but it will heal. And at least they get to keep their leg rather than having an amputation. And now you have to think about how they're going to move around now that they don't have a leg. So
And
we will try everything to save
But
the body part.
in the other side, sometimes the patient gets so infected and we have to save the patient's life. And that situation, and the point is that there's a gray area to see how we can save the limb, and also in the same time we have to save the patient's life. And then to make a decision, need more expertise to see where we should cut that, where should go to limb saving.
because I can imagine, and I know I'm thinking of a situation right now, which I can't share the story in particular because it was private within our organization, but basically, in general, my concern is there is in the back of your mind, a patient has the infection, and while it's not life-threatening at this point, you send them home and with the best recommendations you can, and they get home and you just fear they're going to get home and there's that it's almost like the big question mark, like what's going to happen, things can change overnight. And I'm sure you're thinking, is this patient going to do what I say? Do they have the means to do what I say? Or in 2 days, are they going to be in the emergency room with systemic sepsis because they didn't do as we told them to do? I mean, that's a strong consideration and probably a fear of yours every day as well.
Yet some kind of this kind of patient we need to keep in the hospital to make sure we are assured in situation before sending patient to the home. That's the one of the reason, is the if I have any concern, we're going to get face problem with some kind of the problem as you mentioned. I would keep the patient in the hospital to make sure when we send the patient, at least overall we are safe and we don't want, is this possible? It could get problem, but we try to bring it down the risk as much as possible when we're going to discharge the patient.
And that's when the education comes. You need to tell the patient what really is going on and what can happen if they don't follow and they're not compliant with the plan. You have to be honest and tell them, you can lose your leg if you don't do this. And also we educate them about the signs and symptoms of infection that they should look out. So we don't want to wait until the last minute when it's too late to catch it.
And also we have a choice to send the patient to the SNF or some kind of the nursing measure. They can watch the patient for a while to make sure. And all option we have, point is that we can monitor the patient after that.
What are some of the common misconceptions that patients actually have with wound healing or treatment that you have to correct during your education?
Actually, my experience was regarding the wound care. They thinking they shouldn't take a shower. Actually, the point is that when I close the patient's wound, I can have after 48 hours you can take a shower. If you have open wound, you can take a shower. But the misconception is that for people, they say, no, we shouldn't take a shower. They they are scared to take a shower and clean all the way. That's one of the big misconception I saw a lot of people they have.
The other one is too that they think that a wound should create a scab, and when you have a scab, it means your wound is healed. But that's not like that. The scab is just a wall that, it's dead tissue pretty much. And underneath that wall, there's an open wound. So you do not want to have a scab to close a wound. You want to have the right environment to be able to close that wound. So the scab literally, it's just like if you close the door and there's someone behind that door, and eventually it's going to expose. But at this time, there's infection and there's other things because you let it dry out.
Actually, we just had that habit with my dad. He had hip surgery and he had the dissolvable stitches put in, but two of the stitches we just discovered over the weekend did not dissolve. And suddenly, the incision that looks like it's beautiful, right? All the way up until this weekend, suddenly it starts getting inflamed, right? And you start seeing it bubbling up, and you know that there's something in there, and there were a couple stitches that were left in, and that were causing an issue. But it had looked initially like it was completely healed, and it was great. Something was lurking underneath. So that's a really good point, to make sure to always keep an eye on things. And I have a question about this is my last one, because this is an issue with a lot of our patients. A lot of our patients have poor circulation in the legs, and unhealthy legs indicate an unhealthy body. So people who have poor circulation in the legs likely have poor circulation in their heart as well. 3 in 5 people who suffer a heart attack have peripheral artery disease or poor circulation in the legs. And if they have wounds on their feet, they can't do the best medicine, which is walking. And walking is not only the best medicine for growing those collateral vessels in your legs, the natural bypasses around the artery blockages, but also for your heart. They're your little lifesavers. And you need to get your heart rate up, right, in order to grow those in your heart as well. And the patients can't do that. So what are your best suggestions for these patients that have this poor circulation? They have wounds that are not healing. They can't do the normal. Do you have an exercise program? Do you put them in physical therapy to improve their circulation? Do you tell them to get on a modified, stationary bike? What are your suggestions for these patients to maintain their cardiovascular workouts?
The cardiovascular, if they cannot use the lower extremity, still they can use the upper extremity. My point is that we have a choice. If we have any problem, we cannot use the lower extremity. Still upper body, workout is possible. They can do that. But the point is that we can send the patient to physical therapy or exercise program to help them. And but usually we are in contact with the cardiology, and
Mhm.
in this kind of the cases, to make sure they are based on the situation, we can get advice from the cardiology and to see how much they can work, and with the coordination with them, we can send the patient to some other exercise program.
The other thing that we need to look into it is it a venous stasis ulcer or an arterial? Because if it's venous, we want to make sure that they wear compression stocking to bring that extra fluid from the legs back to the heart. And we always recommend walking. I know sometimes it's difficult, but at least if they wear the compression socks and they do leg exercises, if they're not able to walk, at least do this, that will help bring the blood to the heart. We involve the vascular doctors to see also if there's anything that they can do um, to help them. They are in blood thinners or medications that can help with that as well. And the arterial patients, if they do have wounds, those are a little bit more difficult to heal. So those patients, we try to keep those wounds dry as much as possible. And we involve the vascular doctors as well.
Yeah, we talk to our patients about doing toe yoga where they spread their toes out, bring them in, spread them out, bring them in, and they do flex and point and flex them point and push that accelerator button down and bring it back, and then do the foot alphabet, which are really helpful. Several of our vascular doctors and our physical therapists that we work with teach our patients how to do those and tell them there's no excuse not to move. Doesn't matter if you have a wound, you can move 30 times an hour, do each of those exercises 30 times an hour, and the patients got to do them. There's no excuse not to move because you move it or lose it, right?
Yes.
Well, thank you so much for joining us. I'm curious, just looking into the future, what would be your greatest wish list? How do you see wound care evolving, based on the current gaps in care? What do you want to see going forward that could change the game to improve wound care across the globe?
I think like one of our major problem is like the insurance, that they don't cover much of the resources that the patient need. So in my case, I wish the insurance was a little bit more open-minded, that if we are ordering something for the patient, it's because they really need it. And they deny the whatever treatment we want to get for them, so it makes it difficult for us to provide the better care. So to me, I think the insurance should be a little bit more to have more options for the patients, especially in wound care, because not if the insurance is not a clinical person, they actually don't know what really wound care means, and they don't think that's necessary for the patient and the wound healing.
You mean an insurance company that is not touching the patient and doesn't know the patient's entire medical history and isn't right there with them? They shouldn't be dictating their care?
Yeah, the other
messing with
point
you.
is that we
You,
need to
you're
work on
preaching
that.
to the choir.
Yeah, the point is that we need to work on the prevention. That's my point, is that some
Yeah,
part is that as you're trying to do, that's a very good, point. Try to prevent happening this kind of thing. We can,
yeah.
if they have a vascular problem before causing the ulcer, we should do some kind of the prevention to make sure it's not going to happen, or teach the patient and start the vascular study before causing the wound issues. Or patients obese, we try to go weight loss program before causing problem. Or this kind of the education in the system is integrated the old hospital. Patient make sure is not going to get bed sore, need the teaching part, this kind of and increase the patient now or people knowledge about the wound, and that's one of the most important what you're trying to do. Thank you.
Yeah, definitely prevention is really key, and getting the diagnosis for especially chronic venous insufficiency and peripheral artery disease sooner rather than later. And I know at least for PAD, there is legislation that we're trying to bring back alive called the ARC Act, which would democratize access for testing for PAD patients for those at high risk, such as diabetics, people with high blood pressure, high cholesterol, and those who are over 60 and may have smoked or still smoke. And so that's really, really critical. But I do believe very strongly it is part of our platform. We really believe that the insurance companies need to leave the care to the doctors. And if they don't believe in the care the doctors are doing, well, then don't cover those doctors. And we'll tell our patients which doctors actually have the advanced tools and techniques so that it'll impact their decision. They'll make a more informed decision when it comes to open enrollment every year to make sure that they can get the most advanced wound care possible from clinics like yours that are providing the advanced wound care options that are available to give them the best chance to walk to live another day and live to walk another day. So thank you so much for joining us. We appreciate all you're doing. It's the Los Gatos Private Wound Care Clinic
Yes.
in Los Gatos. Okay. So do you have a website that we can send people to before we close out?
That's called the Los Gatos Private Advanced Wound Clinic, and they can go the Reza Rouhani MD. That's they can website.com.
Fantastic. And if you are watching this and you do want to get connected with Dr. Rouhani and Lehia, make sure you can email info@padhelp.org. Thank you so much for joining us, and thank you all for what you do to save life and limb.
Thank you for having us. Thank you.